it's really important you carve out clinical in that because, as you probably know, the matrix services across the organization, the rev cycle team, the legal team, the cybersecurity team, the IT team, there is AI in every single thing that we do. It's just the clinical stuff, which is the frontline patient care, that actually is getting all the attention. But it's an important part of the industry, kind of across the entire set of verticals and matrices here. But if you really just focus on the clinical, which is really, it's the fun part. I would tell you, I personally really I would divide that answer based on the inputs. AI is really about data inputs. You take deep cuts of data, you run it through the algorithm, all that deep learning, and you're going to help me on my clinical side. I'm going to make a better decision. It's going to give me a recommendation. It's going to steer an action. But it all starts with the data inputs, and for me, they kind of bucket it. There's a triad of buckets of the inputs, and it determines really where those outputs really hit me in the clinical care of patients. So I just look at the raw data standpoint, which is the discrete data, which is, kind of the stuff that's got a value. It's the temperatures and the blood pressures and even the answer of yes or no sometimes for things that, as long as you can make it discrete, we can mine it and use it to feed the algorithm. So the quick summary for me, I would say this: on the data standpoint, in the ambulatory space, we're using it to help tee up the tough clinical decisions. We have an end of life index, which helps us really have the talk that none of us really want to have with patients around what we want to do toward the end of life, and therefore we can help maybe prevent some unnecessary care, some unnecessary suffering. We also use it in our ambulatory space to really find the patients who are at highest risk of no-show, and then we pursue those patients more aggressively, because we want to make sure those are sometimes the patients that are really the toughest to take care of, and they're the ones that struggle for access to quality care. And so by doing that, we extend our access to our patients who need us the most. The hospital answer to that is probably more dramatic, because a hospital setting is more dramatic, but it's hitting quality improvements across the board. Earlier detection of sepsis using the tool, earlier detection of a patient deteriorating. Obviously, the impact on quality is there. In our ICU, we have an interesting tool that helps us determine cause of mortality and basically find variations in care. And we use that as an ongoing monthly root cause analysis to help improve the care in our intensive cares. The ED has some tools. In the surgical space, we have AI tools. We have a risk score to pre-surgically identify patients at risk for a post-op complication or maybe unexpected admission, so that we can give them a little more care and avoid those things. And we even have a tool to help us with our surgical access, to find open spots where we might have a surgical suite that's going to be open, and we can pop a case in and actually reduce our delays to getting to the surgery space as well. So lots of things happen in our clinical space using data. The imaging tools, I think, are in some ways even more interesting to talk about because there is even more dramatic impact. We have tools that are AI tools that are helping us in our valvular heart patients adhere more tightly to the treatment guidelines and improve our quality there, and also make sure that we're not missing any opportunities for recommended follow-up studies. We're using tools for three-dimensional prepping for procedural things. For valve procedures, we have a three-dimensional tool. For orthopedic, people are using it to help template to get better outcomes when they do joint replacements. We have a really large stroke team. In fact, we supply a stroke service to really about our dozen hospitals and another dozen hospitals that aren't us, that just contract us for the service, which is really a way to help make sure that our smaller regional hospitals, our rural hospitals really hit the standard of care for stroke. And in the imaging tool for CT, we actually have that tool helping us more rapidly identify an evolving stroke and get those patients to care more quickly. We have it in our MAM units, helping our women's care, helping us find and determine the decision-making in breast lesions, and just kind of rounding out the space in our OB units. We have a fetal monitoring tool that's running AI that's actually looking all the time at our fetal tracings and helping flag when things might be going south for that baby, and we can intervene more quickly as well. So basically across the board, helping us improve our quality. The last piece, which I think is, kind of the most interesting piece, and it's really the area where this became such a hot topic in the media, is around the language piece, the large language model version of deep learning. And that we're just getting started because that's a fairly new component. We're just about to go live with a tool that helps us identify when there's been a pulmonary nodule that needs to be followed up on, because sometimes that happens is that historically it's an incidental finding, gets buried in the body of the text. And so natural language processing is looking back through our CT chest reports, finding a pulmonary nodule, comparing it to whether or not the recommended follow-up has happened, and then teeing that up for pursuits to make sure that we take good care of those patients and we don't miss anything that we should have been taken care of. We have a tool coming that I'm kind of excited about, that I really just learned about, for our radiologists. It is really just an upgrade of their current dictation tool, but it's one in which there will be an ambient component that will help our radiologist with their documentation, so that it helps create the narrative, so they can really just look at the images and read, and they'll actually put it in a more narrative form. It'll also, I think, more importantly, help trigger based on what it's hearing, will trigger national guidelines to apply and make recommendations to our clinicians, and even actually do some follow-up studies trigger follow-up studies and make recommendations to make sure that those patients get their follow-up. And probably the one that's the most ubiquitous that I think everybody's either doing or talking about doing or about to do is the AI scribe component. We've got a pilot going live in about 4 weeks there. And our plan then is to roll that out to all of our frontline physicians in a broader rollout in 26. So lots of things happening in that space in language. And the one I'd probably end on is the one that I think a lot of organizations are considering now or have just started with, which is an AI chatbot, which is patient facing, so that there is a place where the patient can go, and using an AI tool, the chatbot can actually triage those patients, just get them a simple answer, get them to the right emergency room, get them to the right doctor, to the specialist, and do that more efficiently, and do that in a 24/7 way, and just expedite our access to care. The AI tools are really helping us become better clinicians.